Hello, everyone. We are admitting everyone into the session right now. Welcome to statewide session number 3, preparing to contract with managed care plans. We hear a few of our participants that are not on mute right now. Thank you, everyone that's pouring in. If we could all go on mute, that would be incredibly helpful for us. Thank you all so much. Like I was saying, thank you all so incredibly much for joining us right now. You are joining us for statewide session number 3, which is preparing for contracting with managed care plans part 2. My name is Alexis Taylor. I'm going to be your host for today's session. I am a senior program manager here at Health Begins, and we're just so excited to have each of you here with us today. Moving on to our next slide, we just like to let everyone know that this session is being recorded. And after this session, this content is going to be available on the CalAIM links website that you all can access at healthbegins.org/CalAIM. Moving on to the next slide, we really want to make sure that we are fostering some bi-directional communication for today's session. So if we could all just update our Zoom names and include your pronouns, the name of your organization, we would love to know who we have in today's session. For those that joined us for parts 1 and 2, welcome back to session 3. And for those that are just now joining us, we just want to let you know, from the onset that this is a very dynamic and bi-directional session where we are fostering, questions. We want to make sure that we are meeting your CalAIM needs. So please feel more than free to use the chat to communicate. Please feel more than free to use the raise hand function. And we're also going to have a number of Q&A sessions in which we respond to all of your questions, in which you could unmute as well. So to let us know exactly where you all are within the CalAIM process, we're going to have a really fun icebreaker right now. So to set the tone for our conversation, please let us know your level of comfortability with CalAIM. And so we're going to post in the chat right now 4 options for you to respond with. Let me go ahead and post those right now. Give me just a second. Thank you all so much for everyone that's changing their names and posting in the chat already. And so we have 4 options for you right now that I am posting. And so please let us know, are you someone that is CalAIM curious, meaning that you're not yet sure about whether your organization should contract, or you're still trying to figure out how to contract? If you're curious, give us a blue hat in the chat. If you have some basic knowledge, please respond with the geeky eyeglass emoji that we've gone ahead and put in the chat right there. If you have a solid background, but you're still looking for some of that more, comprehensive information, go ahead. And you're also, someone that can be here as a support to others that are in the chat. Go ahead and give us the hat emoji. And if you are an expert, please give us that Brainiac emoji. And so we are seeing some blue hats. We're seeing some geeky glasses. Oh, we're seeing something new here. We're seeing something different. We see a different type of hat. I love it. I love it so much. And if you do post a different type of emoji, let us know what that reflects, if it's something that is outside of those 4 options that we have right there. For our facilitators for today's session, that gives us a really good idea of your level of understanding of CalAIM. Because like I said, going back to how dynamic these sessions have been and how communicative and bidirectional these sessions have been, we really use this as a quick gauge to understand exactly where you are. And Adriana, I love the blue heart because you can't get the hat. I love it. Thank you all so much for that. And like I was saying as well, just to double down, please use the chat to, ask all of the questions that you have. Our facilitators are going to be monitoring that chat throughout the session to make sure that we're following up on all of those questions. And then if we go to the next slide, our partners at Aurora Health are going to give us a comprehensive breakdown of what today's objective is. But just as a preview, I want to let you know that we'll be discussing contract negotiations, gap filling, and funding sources within the context of CalAIM. There have been a lot of updates that have been happening within the funding realm, and we want to make sure that we get you the most up-to-date information. Moving on to the next slide, I'd like to extend an incredibly special thank you to our project partners. CalAIM Links is a collaboration of Transform Health, Aurora Health Group, and Health Begins, and we are being generously funded by the California Healthcare Foundation. I'll make sure to drop a chat that includes a link to the materials that we're using for today's session, and there are a lot of hyperlinks within that slide deck. So if you want to learn more about any of our organizations, CHCF, Health Begins, Aurora, or Transform, please feel more than free to click on any one of those Learn More buttons, and it'll take you directly to our organization's websites. And if we go on to the next slide, I'd also like to extend an incredibly special thank you to Carlina Hansen, who is our program officer from the California Healthcare Foundation. Carlina has invested an incredible amount of knowledge and resources into making this much needed project possible. So we just want to make sure that we are extending a very special thank you to CHCF and Carlina Hansen for understanding how much of a need there is for TA within the CalAIM space. For those that have not joined us for prior statewide sessions or for any of our CalAIM Links activities, I just want to provide you with a little bit of background that led us to where we are today. So in 2021, we worked with HealthNet Partnership Health Plan and the Health Plan of San Joaquin to host 9 technical assistance sessions that focused on improving contracting readiness and advancing CBO relationships with MCPs. What we have learned as a part of that, or what we learned as a part of that pilot was that the relationship building component within the context of CalAIM is critical. CBOs are quite literally being asked to transform the way that they operate in order to meet service definitions, in order to meet the standard terms and conditions that are required by CalAIM. And so in order to get to that point of understanding those conditions and being able to fulfill the requirements, you have to have the right relationships established. And we realized that those relationships were not in place. So we've been working for the past few years to establish those relationships. And based upon that initial pilot, we had approximately 769 participants join those sessions. The response was incredibly positive. And so we worked to provide this offering within 2022. And so if we go to the next slide, and we learn more about what it is that we're doing with CalAIM Links. We have statewide sessions to which you are joining right now. You are joining the final of our 3 statewide sessions. Such a wonderful milestone, but such a sad moment at the same time, because we've been receiving some really good feedback and activity within, these sessions. And so the statewide sessions serve a very foundational purpose for CBOs and CalAIM stakeholders that are new to CalAIM. We saw a lot of those blue hats, and we also saw some other hats that had flowers on them and blue hearts in the chat earlier. And this is really for you, and also for, those emojis that have like the glasses, the geeky emojis. So we can really give you the foundational information that you need to advance your contracting readiness. In addition to and supplemental to these statewide sessions, we're also hosting county-specific sessions in Kingston, Tulare, Fresno, San Joaquin, and Stanislaus, and Trinity and Shasta, in which we're providing plan-specific technical assistance. And so if you want to join those very plan-specific, county-specific TA sessions, those are available on our website, healthbegins.org/CalAIM. And so the goals of this program are threefold. Number one, we want to make sure that we're recruiting CBOs into these sessions that are rural and or are led or serve communities that have been historically marginalized. We're going to focus on identifying your needs, building your knowledge, and making sure that you have all of the tools and resources that you need to move forward to provide those community supports services. Secondly, we want to make sure that we are strengthening statewide capacity amongst those CBOs that are going to offer those CalAIM community support services. And then lastly, going back to that relationship building component, we want to make sure that we are facilitating local learning, local networking, and also that community building, not only between the CBOs and the managed care plans, but also between CBOs themselves. All of that being said, I am so excited to turn this session over to our partners from Aurora Health. I'd like to introduce Lucy Pagel, who's going to cover our agenda and the objectives. And thank you so much, Lucy, for all that you've done for the past 2 sessions that we've hosted, and definitely looking forward to this session today.
Thank you so much, Alexis. Good morning, everybody. We're still in morning. Today's session, if we could go to the next slide, please. We are really, as Alexis said, going to pick up where we left off last time with more information about what you can expect in the contracting process with managed care plans as community supports providers. So we are going to do a real quick update on CalAIM and community supports for those of you who are just joining and wearing the blue hats or the blue hearts. And then we're going to talk about contracting, the gap filling process that comes once you begin that contracting discussion with your managed care plan specifically. We're going to talk about resources and funding available to you as community supports providers once you are contracted or when you're deep in that contracting process. And we're going to leave some time to just walk through different scenarios so you truly can pull together all the information we are going over today. And then we're going to have 2 breakout rooms, one for those of you who are at the beginning or haven't started the process to ask those kinds of questions. And then another room for those who are kind of deep in the contracting process and want to talk to your peers about how that's going and ask some questions. So that is what we have on track for today. The session objective, which I think we've already touched on a little bit, is to continue to support you all as community-based organizations as you contract with managed care plans. And we'll do that by focusing on the process, the gap filling plans, contract negotiations, and resources available to you. Before we jump in, I know we also did a little bit of this in the chat, but we're going to formalize it a little bit more in a poll. We want to get a better sense of where you are in the process for those of you that have decided to go through the contracting process. Where are you with your health plan? Are you beginning to think about it? Are you preparing materials to have those initial discussions? Have you had a couple of discussions? Have you submitted your certification tool or your application with your plan? Are you in the contracting process, or do you have a signed contract? Or are you just here as a friend of those having a friend of those contracting and it's not applicable to you? So if you could fill this out, we're going to leave it open for probably about 10 more seconds, as long as answers are coming in. All right, so it looks like we're a majority beginning to think about it. Actually, even more folks are non-applicable. So we don't have too many folks that are in the contracting process, which is what we're talking about today. I think this is still helpful information for you all, but I would highly recommend going back if you're at the beginning to think about it phase and start with our session 1 and session 2 after you hear today's session 3, just to kind of fill in the pieces that come before where we're starting today. Great, thank you for answering that poll. All right, next slide. Oh, okay, we just wanted to flag in this slide that we're going to have those breakout sessions later, so we'll get to that later. Next slide, please. Context for today's session. We'll start with, this is our 3rd and final session, as Alexis noted. In our last session, we covered the process of contracting and reviewed provider standard terms and conditions for community support. So these are the STCs, the standard terms and conditions that you as a community supports provider would be expected to follow. These are the conditions that the health plan will build into your contract. So that's what we reviewed last time. Today, we're talking about what comes after that. And so as I said, again, if you missed session 1 or 2, they're on the CalAIM links webpage. That's through Health Begins. So highly recommend viewing those recordings. All right. Building on what we know. Next slide, please. So we're going to do a quick overview of Medi-Cal and Cal Amc so you understand the systems at play here. Again, this material is covered in more detail in the previous sections. So what is CalAIM? This is like the big term. Everybody's talking about it. How does it impact Medi-Cal? So CalAIM is DHCS's, the Department of Healthcare Services, multi-year initiative to implement total delivery system reform over the whole Medi-Cal system. It's payment reforms across the system, and it aims to really innovate programs. It aims to use innovative programs like community supports to improve the beneficiary experience of Medi-Cal. So CalAIM is a huge initiative, and community supports and enhanced care management are components of that bigger CalAIM piece. CalAIM in general is taking more of a person-centered approach and building on the successes of programs that you might be aware of, such as whole person care, the health homes program, that really took a more social determinants of health approach to providing care to Medi-Cal beneficiaries. Next slide. So what does CalAIM do? This is a super fancy graphic that DHCS put together to explain how everything fits together. As I said, it's meant to implement a whole person care approach and address social drivers of health. That's really the crux of CalAIM. There are so many components of the initiative that support Medi-Cal beneficiaries that are meant to work together to identify needs and promote wellness. So within CalAIM, there's a population health management initiative, which is where community supports actually falls under. So community supports is just a piece of this whole approach to really looking at the Medi-Cal population through a population health management lens that aims to support and promote wellness. But community supports and that whole puzzle piece is where we're gonna focus our attention today. There's some overlap with the other programs, and we'll touch on some of that overlap, especially when it comes to funding later on. So community supports, where we're focusing our time today, they're medically appropriate and cost-effective services that are provided in lieu of a higher cost services. So you may have heard these services talked about at the beginning of CalAIM as in lieu of services, and that's because they're meant to be provided in lieu of a higher cost service that's traditionally covered by Medicaid, such as hospital admission or a skilled nursing facility admission, ER use. So the idea is by providing these community supports, you're going to avoid a trip to the ER, a hospital admission, etc. These services, there's 14 of them on the DHCS community supports menu. They're not traditionally covered by Medi-Cal, but they help address social determinants of health, and they can help patients avoid bigger health issues in the long run. They are not Medi-Cal benefits at this time. Community supports are optional for health plans to offer their beneficiaries, and they're optional for beneficiaries or Medi-Cal enrollees to accept. This is why you'll see different community supports offered in different counties by different health plans. They're not, if it were a benefit, if all 14 of these community supports were a benefit, every health plan would have to offer them. But because they are optional, if you're a community provider that offers services in multiple counties, you might see different, with multiple health plans, you might see different offerings. They're really an opportunity. Why would a managed care plan offer community supports if it's optional? And it's an opportunity for managed care plans to contract with local providers to deliver those services that keep folks out of more institutionalized care, such as the hospital or skilled nursing facility. So I'm going to stop here. I just went over a lot to take a quick poll about which community supports of the 14 your organization has expertise in or would want to consider offering. So if you could look through the list on your screen that popped up in the poll, we'd love to hear about what you have experience in. Are you a housing provider? Are you sobering centers, recuperative care, asthma remediation, home-based services? Let us know what your skill set is. And once answers stop rolling in, you can go ahead and close the poll. There's no NA option, that's right. So if you don't have expertise in any of these, you don't have to answer the poll. Apologies that no multiple choices available. If you would like to type in, if you're interested in multiple, please go ahead and we'll fix that going forward if we're to do additional webinars. All right, and poll results. Looks like we have a lot of housing providers, housing transition navigation services, housing deposits. Knowing that you were only able to select one, I'm sure some of you do a couple of those. We got medically tailored meals, home-based services. All right, thank you. Being a network hub is pretty critical. Thank you for pointing that out, and it's not part of the poll, but we'll get in one of our former sessions, I think the second session or the first session, we touched on what a hub model is. So thank you, very critical. All right, next slide, please. CBO stages of readiness. So this is kind of our little pathway to readiness to providing community supports. Today, we're focusing on the aspect of the journey that is becoming a provider that takes place between the initial outreach to your MCP and the application process and becoming officially onboarded by your managed care plan to provide community support services. In August, we discussed how your organization will begin with basic readiness considerations before you are speaking to your health plan. And that should really include reviewing DHCS policy guidance, et cetera. But today we're going to focus on what comes after you've gone through that phase prior to being onboarded by your health plan to be a provider. All right, as a quick refresher again, we covered the basics of preparing. So right now we're going to, we went through the provider standard terms and conditions. So if you missed the call last week, super important to review that document and understand what will be expected of you as a community supports provider. Addressing all your readiness, obtaining an MPI, and reviewing the community supports contract template, which we didn't specifically go over last time, but it's very important. There's a template that DHCS developed that is example contract language that your health plan would build into the contract that you would then be presented with during negotiations. Next. And with that, I believe I'm transitioning over to my colleague, Jill Donnelly, who's going to walk through what happens after when you're in those contract negotiations and you begin the gap filling process. So Jill, I'm going to pass off to you.
Thanks, Lucy. Yeah, so it sounds like a lot of folks are not near this point yet, but I think it is helpful to know that this contracting process is really different than a lot of other contracting processes you may have been through because of the number of standards the plans have to ensure to meet DHCS requirements. So for the most part, what happens is you get into the contracting process and you fill out your application, and then the plan says, hey, let's talk about some gaps that we noticed in your application and how we get them filled before you start delivering services or soon after. So we can go to the next slide. So as I mentioned, you'll submit an application if you're interested in this, and the managed care plan will provide feedback on that application, identify any gaps in organizational capacity, and usually we'll hand you a written gap filling plan. The gap filling plan is a really common tool. It's developed between the provider and the plan to address gaps in meeting contracting requirements. Common areas where managed care plans may ask you to fill gaps include staffing and network capacity to ensure you can meet the demand of referrals coming in, or if you think you already have a lot of members or clients that are eligible for the program, that you could add more on top of who you're already serving. IT infrastructure, community supports have claims and reporting requirements. So making sure you can capture that data and report it out to the plans at the correct frequency will be important. Service provision, model of care, all that fun stuff. and then data sharing and compliance.
Hello.
And again, there are a lot of regulatory requirements here that will be standardized across the plans. So once that gap filling plan is complete and you've worked with your managed care plan,
But I haven't looked at it because I'm on my webinar, so I was going to wait till I get on my computer.
and just no, thank you. So then we get into preparing for contracting and rate negotiations. Sometimes, to be honest, this might happen concurrently with the gap filling plan if time is tight. But more typically, it goes in this order. You get your application, you fill out your gap filling plan, and then you finalize contracting. We recommend, really reviewing that contract if you have, legal folks on staff or on loan, having them really make sure that you're you can meet all of the requirements, ask any questions, request edits or revisions where you think they might be necessary. And of course, making sure that the rate really works for your organization. When requesting an increased rate, it's important, if possible, to prepare a justification of costs or any other relevant information that would help the plan, help justify that increased rate to the health plan. You can go to the next slide. So there are no set rates statewide. Each plan gets to set their own rates. That said, DHCS has developed non-binding pricing guidance, and it's widely available. We'll share the link. This provides example rates of community support services. It includes some methodology, some of the key cost drivers, and represents statewide average costs. One thing to know here is most health plans will offer variable rates across regions, because often it costs staffing and facilities and et cetera cost more in some, some of the denser areas than maybe some of the more rural areas. So, typically those rates are different across the state, but the plans do have flexibility in how much they're willing to offer, and also in how they structure their payment. And if you look at the non-pricing guidance, you'll see some of the, the suggested rates are PMPMs, some of them are flat fees, some of them are fee for service in 15-minute increments. It really runs the gamut. And we can go to the next slide. So, this is going to really vary organization to organization, but some of the other considerations when determining whether the rate is sufficient include staffing models and program need, service offerings and current capacity, whether you'll need to bring in subcontractors, various administrative costs. Again, these are programs with fairly high reporting and claiming requirements, and then various infrastructure costs. Are you going to need a new EHR? Are you going to need new facilities, et cetera? And, again, we really recommend documenting these considerations and methodologies when negotiating with the plans to help justify an increased rate. Next slide. So now we're going to do just a quick knowledge check. And the key points here when preparing to contract are understanding the general expectations of the DHCS provider standard terms and conditions, knowing what materials you need to gather to get that application into the plans, doing some preparation to address data sharing capacity, understanding privacy considerations, which will vary plan to plan, and being ready to engage your managed care plan, review draft contracts, share feedback, and negotiate rates. And with that, I will pass it back to Lucy to talk us through some opportunities for funding that lie outside of those managed care rates.
Thanks, Jill. Okay, there are two big buckets of funding that come from DHCS. Oh, sorry, let me put myself back on video. That come from DHCS specific to community supports, and that you as CBOs may be able to access PATH funding and the incentive payment program. Next slide, please. So PATH, the PATH program stands for, another acronym, Providing Access and Transforming Health, PATH. That's what the funding opportunity is called. The program has $1.44 billion in funding, and it's aimed at a few CalAIM objectives, but a lot of it is focused, most of it is focused towards ECM and community supports. PATH funds are directly for you as providers. They're directed at CBOs, at counties, anybody who's providing ECM and community supports. They are not funds that go to the health plan. And the funds are generally going to providers to maintain, build, and scale their capacity to be able to provide community supports and enhanced care management. There are 5 CalAIM initiatives, 4 of which are directed at specific ECM and community supports, and 1 initiative that's focused on the justice involved CalAIM initiatives. So let's go over them in the next slide, because there's 4 buckets and it's kind of important to understand the difference. So as I said, there's several programs. Some make dollars available to providers directly, while others are targeted to entities working on planning and technical assistance for the providers. Again, they're not available for managed care plans. The Technical Assistance Initiative, it's a technical assistance marketplace. It's scheduled to launch in January 2023 and will provide resources to help ECM and community supports providers stand up their programs. So it'll be a marketplace where you say, hey, I need TA in helping to understand the contracting process with an MCP. And theoretically, there would be a vendor on the marketplace that you could reach out to provide that service for you, and it would be funded through PATH. And I'm seeing questions pop up, but I'll get through it and then we can look at the chat a little bit. So the next is the Capacity and Infrastructure Transition, Expansion, and Development, which is often called the Cited bucket, which makes funding available directly to contracted community supports and ECM providers. So this is very specific to if you already have a contract with a managed care plan or are deep into the contracting process and have a signed letter from the health plan stating as much, you'd be eligible for this bucket. And this will provide funding to providers to really build their capacity. And we'll get into that a little bit more detail on the next slide, I believe. The next initiative is the Collaborative Planning and Implementation Initiative, which supports collaboration among local providers, managed care plans, and other local entities. So it's a facilitated collaboration. So entities already have applied to be facilitators to facilitate the discussions in different regions. And you as a provider in a region would apply to be part of that collaborative and apply to be kind of part of the discussion, but that discussion would be facilitated by somebody else. You can register to participate in that now. So if you're interested in being part of a collaboration in your region with other providers, that application is available on the DHCS website. Lastly, as I said, the Justice Involved Initiative has rounds of funding for local entities to support various CalAIM initiatives focused on the justice involved population. So we won't go too much into that today. As a final note, PATH funding decisions generally align with the needs articulated by managed care plans in their needs assessments and gap filling plans, which are different than the gap filling plans Jill just talked about. Their gap filling plans that the managed care plans have submitted to the state, DHCS. And those are available to review online if you're interested in understanding what needs your managed care plan needs to fill and trying to figure out how you as a provider could play a part in filling those needs. I'm going to take a look at the chat really quick to see if we have anything coming up before I dive further into Cited.
Hey, Lucy, I was just drafting a response to one of these. So there was a great question about which bucket would be most appropriate for whole person care like street outreach. And that's a great question because that was really taken into consideration when the state was building these new programs under CalAIM. And so while street outreach was a part of health homes, for instance, and whole person care, it's not really a part of the ECM benefit in most cases, unless you're meeting all the other criteria of ECM. So it would probably be a better fit for community supports. And there are a lot of community supports that touch folks who are experiencing homelessness. The three big ones are housing navigation, tenancy support, and housing deposits, medical respite as well. So I would guess housing navigation and tenancy support would be a good fit for street outreach workers.
Thanks, Jill. And then I'm seeing another question about the collaborative planning functions. I think there's a little bit, so the collaborative planning that I was talking about are regional collaborations that, folks that were interested in facilitating collaborative groups within regions of providers providing ECM and community supports, including the MCPs. Those facilitators applied with DHCS, and DHCS is in the process of selecting who's going to facilitate regional conversations. And then at the same point, as providers interested in participating in those discussions, you can apply to be part of them. They are not, it's not a regional network hub in the sense of a hub of community providers that, the health plan would contract with a hub of that would then have different providers that they're contracted with. It's not a contracting hub, if that makes sense. I don't know, Jill, if you want to explain it any better than I did, but it's different than a community provider hub.
Sorry, Lucy, I was answering a question about promotores and
yes.
CHWs.
For that answer, I think the bucket would be the Cited bucket to build capacity. For the bucket, if you want to hire CHWs and promotores, but for the collaborative planning functions, CBOs and others can apply through DHCS to join the collaboratives. They're not up and running yet, and they're not contracting collaboratives. They're not hubs in that sense. I hope that answers your questions. I'm sorry it wasn't super clear. Okay, now we want to dive specifically into the Cited bucket of path in a little more detail, because I think this is the bucket that will be helpful to you in understanding that this resource is available if you should choose to contract with a managed care plan. It's really to help with expansion and development of community supports. It's really to build your capacity. And anybody can apply who's providing contracted to provide ECM and community support. So this could be the county, the city, public hospitals, CBOs, tribes and designees of Indian health programs, but you have to have that contract with your managed care plan, or as I said, be very far along in the contracting process to the extent that your managed care plan would sign a letter saying that they do intend to contract you to be able to access those funds. Next slide. All right. Possible uses of the Cited funding. So this kind of gets to the question of, could you use it for CHWs and promotoras? It can support workforce, IT infrastructure, build upfront funds to build capacity, evaluation and monitoring, outreach, and it's a pretty broad bucket. They're not, the Cited funds are not geared towards program administration ongoing. They're not ongoing funds, so they shouldn't be thought of as a sustainable funding source that will take you through being a provider forever. They're meant to be tied to specific activities like the ones I mentioned here. Let's take a look at some other opportunities on the next slide that you may be able to take advantage of if you're not already contracted as a community supports or ECM providers. So this would be the technical assistant marketplace component of PATH. That is, it's not up and running right now. It should be up and running in starting in January is the goal of DHCS. This technical assistance is going to be available to providers, CBOs, counties, et cetera. And how you would access it is registering or is by looking at the marketplace, looking what the marketplace has to offer. And then there'll be some sort of process that I don't think is outlined by DHCS at this time about how you would go about accessing the TA that's offered on the marketplace and getting that covered through PATH. Some TA resources that might be available through the marketplace. Again, it's not live yet, so we don't know exactly what kind of TA is available. Could be trainings for providers, guidance on data sharing, TA, the ability to hire somebody to help you understand data sharing and help you walk through how to improve your data sharing systems. Off-the-shelf learning modules, strategic planning and project-specific support around community supports and other aspects of ECM as well. Again, this is probably going to go live in January, and there'll be more information in the coming months from DHCS on this. Are we getting any questions, Jill, that I should flag?
So there are a few more questions about becoming a convener, there are the comments are correct. It was a closed application period and it's no longer open to our knowledge. But there is an effort by some counties in particular and other public entities to talk to the state about becoming facilitators. So that's all correct. But there's not a lot of information available right now about who was selected to be those convener, to be those vendors. A question about whether there's a public list. No. Again, that hasn't been announced. You typed just quickly enough. That was perfect. Hasn't been announced. We expect it to be announced soon. I think they're trying to move pretty quickly on this. But yeah, it's we expect DHCS to release more information this fall.
I don't think there's an email list for the updates for the technical assistance marketplace. I really think a lot of this is fast moving. So just checking the DHCS website on this a lot. There's a path specific page for CalAIM. I'm hoping somebody can drop it in to the chat. There's a path specific page that has little buttons at the top for all of the buckets. So there's a cited. So the cited application, for those of you that are contracted or very close to the end of the contracting process, the first cited application period ended September 30th. So we're a little late for that, but it is expected to open again in not too long. And so there are multiple rounds of cited funding. This first round is closed. The second round will open up and there'll be kind of rounds through 2024, I believe, to apply for cited funding. So your opportunity is not gone just because this first application period is closed, though you won't be able to apply for retroactive funding back to January 1st, 2022 at this point.
And I'll mention, Rishi very helpfully put in the TA marketplace site. Right now, that's really just active for people who are interested in being vendors on the TA marketplace. They're not quite ready yet for folks to, purchase services there. But as Lucy said, they're hoping to have that all up in January. There was a question about which funding bucket would be appropriate for short-term residential treatment program.
I think it would depend on what you wanted to fund about that.
That's right. Yeah. So if you are a contracted provider with a plan under ECM or community supports, more likely, Cited would be probably the most appropriate.
And again, the cited period closed on September 30th, but it will open again. And I believe the site has the predicted date of when it will open again. I think it's not too far away. And as I said, that's ongoing availability to apply for cited throughout 2024.
I think it's also, and maybe Lucy, you said this, but it's worth mentioning that the TA marketplace will be at no cost to providers. So once that opens up in January, you'll be able to go on and request to purchase services or a toolkit or TA help from a vendor, and that will be funded completely through PATH dollars. So it will not be at any cost.
Yeah, and we just don't have more details at this time about what that process is, of how you'll request the vendor and the funding. But as I said, I would be checking that PATH website, as everything's happening pretty quickly at this point. All right, let's move on to the incentive payment program. So this is another funding stream to be aware of. This is specifically available to managed care plans. The funds go from DHCS to the managed care plans. And it's to support investment and expansion in ECM and community supports in domains like care management capabilities, infrastructure, IT, workforce development, et cetera. So this is a bucket of funding that the managed care plans get, that they can trickle down to you. And we'll get a little bit more into that later. So in the first year of the program, which is this current year, DHCS prioritized IPP funding for capacity building, infrastructure, community supports, take up, and quality. So trying to encourage health plans to take that option of offering community supports. So to get that funding, managed care plans needed to submit the needs assessments and the gap filling plans that we talked about a little bit earlier, that are the gap filling plans are available online, to demonstrate their need, to demonstrate how their plans wanted to meet the needs to build up their capacity. So even though, as I said, IPP funds are direct to MCPs, providers can work with their MCPs on the gap filling piece. So this is where it becomes important to maybe review those gap filling plans that are online, that are different than the gap filling plans that you would work with your MCP on during your contracting process. But anyway, look at your MCP's gap filling plans and see where you can fit in to helping them fill the gap, and then work with them to request IPP funds from them, from their IPP funds that they're getting from the state, to help them fill those gaps and meet what they said they would do for the state with their IPP dollars. So the gap filling plans do include a specific section on community supports, provider capacity building, and take up. So if the health plan is saying, hey, I don't have enough providers in my network to offer medically tailored meals, and you're a medically tailored meal provider, you could go to your plan and say, hey, I see you have this gap. Let me help you fill it, and request that they trickle down that IPP to you to help them fill that gap. So that it's a little less direct way. PATH is directly for providers. IPP goes to the managed care plans first, but they need to use those IPP dollars to fill gaps, and that's where you come in. Any questions on IPP? It doesn't look like it. So some, especially in counties that had whole person care, and jumped on early providing community supports, they may already have received or begun receiving the plans IPP funds from the plans. But this is something that will be ongoing in future years. I see a question: can counties apply to be a TA vendor? I think I can't speak to the TA marketplace, but I think if you take a look at the application, and see if you would qualify and have expertise to provide technical assistance, and kind of go through the DHCS channel on that. Does state publish information about which plans received IPP funds and the amounts? Jill, if you could, I think they don't post the amounts plans received.
No, I don't think so either. Not to our knowledge. The plans, there is some reconciliation, because if the plans aren't able to show progress on their IPP investments, there is sort of like a pool. The money gets thrown back, gets clawed back and thrown back into, and goes to the higher performing plans. But I don't think any of that's public.
don't think so. All right, those are the main funding. That's the funding coming from DHCS to support community supports. It's huge amount of funding. It's really focused on capacity building, and the goal of both pieces of funding is really to encourage community providers to participate and to provide both ECM and community supports. So definitely know that that is available to you in a variety of capacities as you consider whether community supports are right for you. All right, to kind of finish up this section, we just want to talk about some additional considerations as you, prepare potentially to be a community supports provider. Next slide, please. So reviewing some readiness activities that we've kind of gone throughout these 3 presentations are reviewing the managed care plans models of care. This is something that is not public online, but this is something as you become a contracted provider with a managed care plan, you can request to see their models of care to better understand how their vision for providing community supports in ECM. You can also just request to see their plan for community supports. The model of care is huge. So if you just want to understand that piece, that's something you can request. Again, plans will be, more willing to share that if you're a contracted provider and they're not published online. You may also want to assess whether you need to take internal steps to develop new workflows, organizational policies and procedures to prepare for reporting to a managed care plan and develop a claim submissions process. Because these are Medi-Cal services, Medicaid services, there are pretty strict billing and invoicing requirements. You are allowed to invoice if you don't have the capacity to submit formal Medicaid billing, but these processes are more they take a lot of resources. So just understanding if you have the resources available, or you might need to hire a third-party vendor or a clearinghouse, et cetera, to help you with the billing is definitely something to consider as you consider your resources and ability to provide community supports. You may need to hire new staff to make all this happen. You may need to hire new billing staff. You may need to hire more providers within your CBO to be able to meet the needs. You want to test all your systems and workflows prior to go live. So for example, with billing, before you start offering service, you want to work with your plan to test your billing submissions, make sure that you're submitting everything in the right format, that the health plan is receiving it, and that there are no challenges with that workflow, because billing is complicated and you all will rely on being paid for the services you provide. So want to make sure that's going well before you go live providing services. Let's see, what else do we have here? Reviewing member information files. So in some cases, the health plan will send you a member information file of folks to reach out to see if they would like to receive a community support. So just being familiar with your plan's member information file, what that looks like and how often you can expect it and how the plan's going to send it to you. And building that into your workflow is important to understand as well. Again, that's just a smattering of other readiness activities to consider as you think about becoming a community support provider. I think let's dig a little bit further into billing and invoicing. I touched on it a little bit on this slide, but just to understand the expectations around billing and invoicing for providers. You again, want to consider your capacity to submit claims and bill for the services you're providing. This is not a grant program. You will provide services and your health plan will want a claim or invoice for those services, and then your health plan will pay you for those services as in a way you've negotiated in your contract. You are allowed to, again, submit invoices, but your plan, you'll have to work with your plan on what that looks like. You can submit via mail or electronically. I would say electronically is the way to go for tracking and for quicker turnaround with the plans. If you use snail mail, things could get lost. It'll take you longer to understand if the plan has denied your claim or approved it or has questions, etc. Plans have been encouraged by DHCS to develop standardized templates and billing portals when possible. And they're encouraged to provide training and education to you all as CBOs newer to Medi-Cal billing. If you're new to submitting claims and invoices, it's really important that you ask for this training. Perhaps if your health plan doesn't offer the training that you need, this might be something you'd look for in the TA marketplace. Just to understand how to avoid denials in billing, to understand your health plan's process, to understand if you have the capacity to do the billing, or maybe you want to hire a third-party vendor. These are all considerations when you're thinking about billing and invoicing for community supports. DHCS has some billing and invoicing guidance that I believe should be dropped into the chat. And highly recommend reviewing that. Next slide. So this guidance has the minimum data elements that providers need to submit when they're submitting, if they're submitting an invoice. If you're submitting a claim, it's pretty standardized form. The data will get rolled up into the managed care plan's quarterly report to DHCS. And providers submitting invoices can use an Excel workbook, a web form, or portal, but you just have to make sure whatever format you're using to submit your invoices are approved by your managed care plan. And I see a question, is it accurate to say that billing is all fee-for-service for community supports and ECM? What happens when the CBO cannot reach the member for services? I would say it is not accurate to say that all billing is fee-for-service. I think plans have gone about it different ways. There's some PMPM, there's some fee-for-service, and it is both dependent on the plan and what the community support is. Some are better suited for a fee-for-service model, and some are better suited for a PMPM.
And I would add, yeah, I mean, there is risk to providers that, if members are not able to be reached, in some cases that they may not be able to get paid that month for that member. So, and that could be under community supports or ECM, under fee-for-service or a PMPM model. So it's not zero risk. It's not exactly like a capitation where there's guaranteed payment if you're under contract. But plans also are very aware that, a lot of the population served under these programs are not able to engage every month, or they may move or switch plans. So most of them have accounted for that in some way in their pricing and payment model. So for example, if a plan is paying a PMPM for a provider to provide ECM services, that's usually a monthly payment, but most plans will make that contingent upon, did you actually talk to the member this month? Did you walk with them to an appointment? Was there some sort of service provided? And let's say there was a service provided in September. In October, that person, they weren't able to be reached. And then in November, they came back and they got re-engaged in services. The plan might claw back the PMPM for that middle month, but the PMPM would start again once service is resumed. And all the plans do that differently. So we that's a generalization, but not being able to provide a service in a given month does not kick someone out of the program per se.
Yeah, and Jill, this is Cynthia from the Health Plan of San Joaquin. So I will just add that is accurate. There is a difference between ECM and community support services. And then for the community support services, something to keep in mind, those may also have different frequencies. So as an example, there could be, a per meal reimbursement, there could be PM, there could be per diem, per day frequencies in some instances for those services in accordance with that pricing guidance.
Thank you, Cynthia. That's helpful. All right, next slide. That kind of wraps up our funding and then billing and invoicing piece of the discussion today. So just a little knowledge check. What we talked about when thinking about payment considerations, just consider those funding opportunities available to you. If you qualify for them, how much they'll help you, how you can build that funding into building your capacity and being prepared to provide community supports. Think about, specifically Cited and technical assistance marketplace for you all. Again, Cited is closed as of September 30th, but will reopen again. And those are the funds you can use to build capacity and infrastructure. The technical assistance marketplace is not open yet, but should be open in 2023. And that is somewhere you could go to get help with contracting and data sharing. And, there'll be vendors to help you through those pieces. Think about all the other components of being a provider, making sure that you're able to bill or invoice for the services you provide, and that you are able to build workflows to make sure that you're tracking your billing and making sure you're getting paid or addressing denials as it may be. All right, next slide. So I think we just wanted to go over a few scenarios that kind of take our learnings from today and just, frame them up a little bit. So for example, a local community organization has experience providing asthma remediation services at home and home modifications, and they're now interested in contracting to become a community supports provider. Where would they start? I think there's a poll. So what's the first step once you decide you want to become a community supports provider? Do we have a poll for this?
No, we do not.
Okay. All right. So I think, the first step is just seeing if you are ready. Do you have the capacity to provide? Do you understand what's expected for the community supports you want to provide? Do you have you gathered all your organizational information and have the internal resources to begin that process with your managed care plan? The first step here is not to just reach out to your managed care plan without understanding what would be expected of you as a community supports provider. So definitely gather that information and understand what it means before you reach out to your health plan. All right. The same organization, sorry, did you have something?
I just wanted to mention there was a question about kind of where to start if this is feeling a little overwhelming, which we really understand if it is. And the DHCS links we've shared are a great place to start. And I just want to mention that there are, we can try to highlight some more introductory PowerPoints that are on there and provider guides, things like that, that might be a little more kind of digestible initially.
Yeah, and I would say our first webinar in this series really takes a huge step back from this level of detail and has a lot of the links to the beginning DHCS documents we would recommend reviewing. So I don't know if somebody can drop the link to the first webinar in this series, but I would, starting there is really taking that step back, like what does it mean to be a provider in the Medicaid system and Medi-Cal, and how do we even think about community supports in our role to begin with? So.
Yeah, thank you so much, Lucy Angel. Sorry, my voice is a little bit raspy right now. I just want to double down on that for the participants that shared that this is a lot. It is a lot, right? And that's exactly why we're hosting these sessions, because we understand that it's a lot of information to soak in and that it was not going to get soaked in within just this one session. So I just want to make sure that is not a singular or a linear experience. That is what everyone has experienced. And so I'll repost the links to the prior two sessions that are the lead up to the material that was hosted today. So that way, it can make sense, so that way the narrative can, read out in just a much more succinct way. And so I'll make sure to post it in the chats. The videos and the slide decks are available. And then after that, if you have any questions, we do have the CalAIM@healthbegins.org email address available, and we can redirect you to our plan partners as needed to make sure that you have all of those questions answered. And all of those slide decks also have the links that have been shared throughout these sessions. So sorry again for the raspiness, but just really wanted to double down on that it's a lot of information, and that's exactly why we wanted to make sure that we were hosting these sessions.
Thanks, Alexis. I'm looking at time, and I think because we don't have the surveys, the polls linked for this session, I think we'll just move to our breakout groups. So we have some time to answer dedicated questions, and you have time to talk with your peers about everything you've learned today. So we're going to have 2 breakout rooms. One is for those with, who are CalAIM curious or just beginning to think about contracting. You're going to select breakout room 1, and there we're going to talk about more. You can ask questions that are more foundational about Medicaid and CalAIM. And breakout room 2 is for those who are engaged, who are kind of beyond having the basic knowledge, but more actually beginning contracting discussions with your managed care plan. So if you would like to select a room, we can just have a more dedicated discussion with folks who join. So join group 1 if this is a lot for you, everything that we've talked today. If this information we're talking about today is right up your alley of where you are, select breakout room 2. All right. Thank you all for rejoining. I hope that you had fruitful discussions in your groups. I know our group, really interested in learning about how how community supports and CalAIM fit within the broader Medi-Cal program. So we had good discussions. Does anybody want to share what you discussed in the other breakout group? Any summary? You don't have to. We didn't tell you you had to, but if you have any learnings, please unmute yourself. Right. In our group, there was an offer by Health Begins to connect folks interested in medical legal partnerships with a working group I think they have at Health Begins. So Alexis will be, if you want to reach out to Alexis to learn more about that, please do so.
And Lucy, we had some great conversation around some concerns around how to braid funding, how to avoid, any double dipping when there are multiple funding streams involved, sort of timing a PATH application with an ECM application and some of those MCP findings. Do you wait to hear from the MCP or go for PATH before you've heard from what they think you need to close? And then also, some ideas about collective action around rates, and kind of putting together cost analyses or justifications to help the plans understand a request for an increase in rates.
Wow, super great discussion. You guys got a lot into your 10 minutes. Awesome. Thank you, Jill, for the recap. Next slide as we wrap up. All right, our takeaways today. First of all, if today was like, I'm sorry, what? Please go back, start with session 1. And for those of you who really want to start at the basics of Medi-Cal, especially my breakout group, I'm going to think of what I can get Alexis to then get you to just kind of start even farther, to just the Medi-Cal system is very complicated without CalAIM. So we also, we want you to understand that there's a gap filling process. When you reach out to contract with your plan, it's probably not going to be like, hey, you look great, here's a contract, on your way. There is a discussion and working together to fill gaps and make sure that you're truly working with your plan to make sure as you start providing services, the beneficiary is getting the services, you're getting paid for them, you have everything you need set up before providing services. And we just want you to understand those resources available to you. PATH, especially PATH, Cited. Look at that and understand that you do have support from the state to build your capacity and do what you need to do to become a successful community supports provider. and look for the TA marketplace in January. And I think with that, I'm passing to my friend Alexis to close us out.
Yeah, thank you so incredibly much, Lucy. And I just want to thank everyone for joining this session. Our breakout rooms were incredibly successful today. Jill, thank you for providing the overview of what was discussed for the more advanced group, because as compared to the group that we had, that is CalAIM Curious, the breakout rooms are spot on, you know, with the questions that are being asked, with the level of readiness, with where these CBOs are in their contracting readiness. And I think that for the CalAIM Engaged group, it's so awesome to see that at one point they were CalAIM Curious, right? And to see exactly where they are right now in this process. And then for our CalAIM Curious group to understand that you will, you know, pretty soon be in that CalAIM Engaged group. So that's just a really awesome progress for us to be able to see in real time and in person. For those that are in Fresno, San Joaquin, Stanislaus, Kings, Tulare, Trinity, or Shasta, we will have some county-specific sessions that are coming up. We would love to make sure that everyone that is in those counties, you know, takes advantage of the county-specific information that's going to be shared. So please visit, you know, our website. I'm so sorry, I think there's someone that's not on mute right now. So if everyone could make sure they're muted, that would be so helpful. So we are going to have those upcoming county specific sessions. And if you are in any of those localities, definitely visit our website, healthbegins.org/CalAIM, so that way you can RSVP for those sessions. But before we go into our wrap up and our special thanks, we just want to take one last look at the chat and then just welcome, you know, anyone that does have a question to either go ahead and post it in the chat for us. Sorry about that, or to unmute to just let us know if there's anything that we missed, because we want to make sure that we're just sharing as much information while we have you right now in this session, so you can walk away with as much knowledge as possible. And you'll also have access to these resources that include all of the links that were shared throughout the chat today. And thank you so much, Joe, for posting that billing guidance. And I think that we may have responded to, oh, I do see one question. I didn't get a chance to ask this question. I was wondering if there are any trainings for billing currently available that we can undergo. Yes. So dependent upon the county that you are in, each plan's website is going to have a list of trainings that are available. And those trainings are also going to include trainings on billing as well. And so those are very plan specific questions. So like I was saying, going back to those county specific sessions that we're going to host, if you're in any of those counties that I referenced earlier, we do have the plans available in those sessions for you, so that way those specific questions can get answered. But based upon that county, those trainings are also available on their respective websites. And all right, I think that we are good to go to the next slide. Yeah. All right, so just as a reminder, as I let everyone know, the recordings of the sessions, including sessions 1 and 2, are on the CalAIM Links website. So especially for our CalAIM Curious cohort, please feel more than free to go ahead, review those sessions in the correct order, so that way the information that you received in today's sessions can resonate even deeper. And it can even foster some additional questions that you may have after watching those sessions progressively. You may be able to formulate questions that you hadn't thought of prior to watching sessions 1 and 2. So please go ahead and visit that website for all of those resources. And if we go to the next slide, we just like to give a very special thanks to all of our project partners, which includes, and if we go to the next slide, sorry about that, our partners at Rare Health for developing all of this content that was presented today. So much thanks to Kathleen Kane, that did not present today, but on the back end contributed a lot to developing the content. Our facilitators, Jill and Lucy from Rare Health. And if we go to the next slide, our partners at Transform Health, who also are able to provide input on the content that we deliver on all of our statewide and county sessions. And if we go to the next slide, our internal team here at Health Begins, whom I appreciate so much for executing this project with me, which includes our CEO, Rishi Manchanda, Melissa Meza, Sadhna Devaraja, myself, and Shiva Demon. And then lastly, we are being evaluated by Mount Auburn Associates, who ensures that the work that we're doing is meaningful and has, successful outcomes. And once again, just thank you so much for everyone that joined us for today's session. Review our website for the upcoming county-specific sessions that we're going to have, and we'll be in touch with everyone with this recording, the links, and the links to the content as well. So thank you all so much. Until next time.
I have a super quick question, sorry.
Absolutely. Absolutely. Thank you.
By the way, thank you guys so much for, everything you guys have done and all the information provided. We appreciate it. So I'm currently on the website, I'm trying to locate because we're in Fresno County. So we definitely want to do the upcoming webinars and information sessions and stuff. But to be honest, I'm having trouble locating that, or is it not available yet, but it will become available?
So thank you so much, Giovanna. If we do not have the links for the upcoming Fresno session that's going to take place in November loaded yet, we will definitely get that up. And because we have your email address through registration, we'll also send you a direct email and reminders for that session as well.
Thank you so much. In case I don't hear, for whatever reason, I don't get an email, who can I follow up with?
That would definitely be myself. So you would be able to email me directly at that CalAIM Links website, at that CalAIM Links email address, which is the calaim@healthbegins.org. But I'd also like to go ahead and drop my primary email address for you in the chat as well.
Thank you so much.
No problem. Thank you. And so in addition to having that registration form uploaded on the website, we'll also reach out to all of our Fresno participants on that list. So we'll make sure to add you to that list and get you the invites and the reminders for those upcoming sessions. We have 2 sessions that are remaining for Fresno County. Perfect. Thank you so much. And then did we have any other final questions? I know that we have a smaller group of about 32 right now, but please feel more than free. Not in a rush to hop off right now at all. All right. Well, thank you all so incredibly much. Please feel more than free to email me directly or to email us at that CalAIM Links website, and we'll be in touch soon. Thanks, everyone.